Good afternoon and welcome to the Health Technology Wales training session, Appraisal Health Technologies in Value in Health Week. My name is Dee Puckett. I'm the Head of Health and Care Engagement at the Life Sciences Hub Wales, and I'm also the Senior Lead for Value-Based Healthcare and Industry. The Life Sciences Hub Wales is a wholly owned subsidiary of Welsh Government, and our role is to work with industry and across the health and social care landscape to identify the key challenges and opportunities for innovation, co-creation and collaborative projects, which in turn support better outcomes and experiences of citizens in Wales, enable better utilisation of resources and to encourage economic growth across Wales. We're really pleased to be hosting and delivering this Value in Health Week session in partnership with the National Value in Health team and Health Technology Wales. We're really pleased to be offering this virtually. This is the first time for this session. Hello to those of you who joined us on the first session on Monday, and to those new people, the first session will be available on a recording. We've got over 120 registrations, which is fantastic, right the way across industry, academia and health, demonstrating the interest in this area. There's still plenty of opportunity to register for other sessions during the week. So this is our 14th session. We've still got 11 sessions across the rest of the week of different case studies and expert panels. So please feel free to register. So without further delay, I'll hand over to Dowie and the team from Health Technology Wales.
Good afternoon. Thank you for the introduction, Dee, and thanks to everyone else for joining us today. Welcome to the webinar. My name is Dowie. I'm the Communications Officer here at Health Technology Wales. We're pleased to see so many of you join us for this series of free virtual events and to see so many of you coming back following our health economics session on Monday. Before we get going today, I should start with some brief housekeeping. Today's session is called Health Technology Assessment 101, and it should last around 90 minutes. For those of you who joined us on Monday, we'll follow a similar structure today. I'll give a brief overview of Health Technology Wales, explaining who we are and what we do. And then I'll hand over to Lauren and Jenny, two of our staff, a health services researcher and an information scientist, to deliver the webinar. This should take, that section should take around 60 minutes. And in that time, all you'll see will be the slides on the screen. You won't see our faces until the Q&A section that follows the presentation. Questions, though, can be submitted at any point of the presentation as we go along, and they'll appear in the questions chat box. You'll see that when I send a couple of prompts throughout the course of the presentation, so that we address the questions that you collectively as the audience want answering the most. We're going to ask you to give a thumbs up to your favorite questions, and we'll prioritize answering those first in the Q&A section. So let's get going. Health Technology Wales was set up by ministerial recommendation in November 2017. We're funded by the Welsh Government, hosted by Velindre University NHS Trust, and in more normal times we're located at the Life Sciences Hub in Cardiff Bay. Our remit is to provide a national approach to the identification, appraisal and adoption of non-medicine health technologies into health and care settings in Wales. Now, that's a very broad church. It covers a lot, as you'll see over the course of the next hour. Anyone from any background can submit a topic for Health Technology Wales to appraise, and if there's enough evidence for that submission, it will be added to our work programme, and we'll assess the technology for its clinical and cost effectiveness. If a technology topic makes its full way through our process, we'll issue independent authoritative guidance based on the best available evidence and expertise. This is then used to inform commissioning by NHS Wales, and decision makers are able to make evidence-informed decisions. That is a very quick summary. I'm mindful not to steal any thunder of Lauren and Jenny over the course of the next hour. If you're on social media, check out the Health Technology Wales account on Twitter, tag us in your posts about this session. I'm going to hand over to Lauren and Jenny at this point, and hope you enjoy the next hour and a half.
Hello, I'm Lauren Elston. I'll be starting the presentation today. Let me just, okay. So what we're going to cover today is who Health Technology Wales are and what we do in a bit more detail. What are health or care technologies? What is a health technology assessment? That is the bread and butter of today. Developing the selection criteria for appraisal, which is another word for assessment. Identifying relevant evidence for that HTA, critically appraising evidence, and how you can propose a technology to Health Technology Wales. So as Dewi said, we support the identification, appraisal and adoption of non-medicine health technologies in health and care in Wales. Today we're going to be focusing on the appraisal or HTA function. What do we mean when we say technology? It's not necessarily what you would expect in when you use technology in normal terms. So there is a definition here from the HTA glossary: an intervention to prevent, diagnose or treat medical conditions, to promote health, to provide rehabilitation or organise healthcare delivery. So Health Technology Wales covers all types of the non-medicines technologies, basically anything that isn't a pharmaceutical. So that can include devices, diagnostics, surgical procedures, clinical interventions, organisational interventions, psychological therapies. So on this slide here, we've got some examples of what would be considered a health or care technology. As you can see, it can range quite vastly from simple everyday objects like stress balls, fidget spinners even, to things that are more complex like the machines, diagnostics. It doesn't have to be something that is physical. It can be a digital application, it can be a surgical procedure or physiotherapy, it can be something that's used by organisations or something that the patient or service user can use themselves. So the term non-medicine health technology does cover a very broad scope of interventions that we look at. So the next question is, what is health technology assessment? This is another definition here from the HTA glossary, which can be quite useful. There's the link there. The systematic evaluation of the properties and effects of a health technology, which we've already covered what health technology is, addressing direct and intended effects of that technology, as well as the indirect and unintended consequences. And the whole point of this is mainly aimed at informing decision making regarding health technologies. And it is usually conducted by an interdisciplinary group using different analytical frameworks that can draw on different methods. And we'll get more into that later. So as I said, it's a multidisciplinary field and it addresses the clinical, economic, organisational, social, legal and ethical impact of technologies within specific healthcare contexts. It includes looking at all of these that you can see on the slide. So we look at the health problem, where there might be an unmet need or a condition that needs intervention. The health technology itself, what is it? How would it fit into the current pathway? Would it be replacing something or would it be a new addition to that pathway? We look at the clinical and cost effectiveness of the new technologies. Any organisational issues, for example, if there are training requirements with the new technology, any extra resources or capacity, or even any extra resources or capacity that are released by implementing this new technology. And of course, we also take into account patient issues, which include experiences and considerations identified by the patients. All of this feeds into informing what the health technology's value is for healthcare providers and patients and service users. So here is a basic outline of a technology life cycle, from innovation through to regulation, through to adoption and reimbursement, and even at the end to disinvestment. When we look at where HTA can be used, the answer is it could be applied at any of these stages. Early on, it can be used to help inform the development of a technology and inform those investment decisions. And then later on down the pathway, it's used to help inform policymakers or care providers on implementing new technologies. For example, with the reimbursement decisions for the NHS in the UK, it can also be used as to whether to help decide whether the technology should be adopted on a more local level, so by individual healthcare providers or even on individual person levels, depending on the technology and the context that you're looking at. And finally, if there's some uncertainty about established technologies that are currently used in health or social care, then that could be HTA could help inform whether or not such technologies should be continued to be used. So that's the disinvestment decisions. In the UK, medicines have to go through quite a strict process. They are approved by a regulator like the EMA, and then they can be evaluated on a national level, such as the National Institute for Health and Care Excellence, which is NICE. In England and Wales, NICE's funding decisions for medicines are mandatory, so adoption isn't decided on the more individual local level. It tends to be more of the national coverage. This isn't what you see with the non-medicine health technologies that HTW focuses on. This is the medical devices and diagnostics, and even some applications, digital applications, do need regulatory approval like CE marking, but there isn't necessarily a national HTA for reimbursement, and that's why Health Technology Wales came to be, to help try and make that national local coverage decision for the non-medicines. Why do we need this HTA? So as I touched on before, the national healthcare providers like NHS Wales have a finite resource to provide that care, and even if there wasn't a finite resource, if it was unlimited, you still wouldn't necessarily want to pay for products that aren't effective, or if they're unsafe for use. It's about getting that value for money and making sure that the technologies do have enough benefit to justify additional cost. It's also helpful for reducing variation. So by doing these national coverage and national HTA, you can help with the provision of care, equity of access, reduce variation in payment that you can sometimes see on local levels. And it can also help speed up adoption by getting effective technologies into the NHS more efficiently. Our reviews, our evidence reviews, which we'll go into detail a bit more later, are based on rapid review methodology for this reason, to try and help a quicker response to service and get those effective technologies into service quicker. There are lots of different organisations that undertake HTA. Here's some that I've listed here for the agencies in the UK and Ireland, such as the National Institute for Health and Care Excellence, NICE. That's a big one that you have probably heard of. There's also the All Wales Medicine Strategy Group in Wales and Health Technology Wales as well. We are the national for Wales. Scottish groups are the Scottish Medicines Consortium, Scottish Health Technologies Group. Again, SMC focus on medicines, SHTG focus on non-medicines. And then in Ireland, there's also the Health Information and Quality Authority, HICA. And these kind of organisations exist throughout the world. There's a map here of the current membership for a group called IANATA, the International Network of Agencies for HTA. And here are a couple of other examples of these kind of membership groups. UNETA is European, HTAI is HTA International, and there's lots of different members there from around the world. This next slide just shows an example of the generic health technology assessment process. It's a very high level overview, and we're going to go through the steps in a bit more detail from the HTW's perspective. These processes can be rapid or full, longer, ranging in time from 3 months to a year, depending on the agency and the type of methodologies they use. So you start off with identifying a topic, which can also be through notification or horizon scanning, through to selecting, prioritising, and adding that topic through onto the HTA programme, defining what that topic will be in a research question, and then usually it's a fuller evidence review followed by appraisal or decision making. And sometimes that can follow with another review before guidance publication. And as you'll see from the next slide, our process at HTW is very similar, from topic identification through to defining that protocol research question and writing a review through to the appraisal, production of guidance, and then publication, dissemination. To start with, is the topic identification. At HTW, people can notify us of topics through our suggest a topic form on our website. As Dewi mentioned, anybody can suggest a topic to Health Technology Wales, whether you're from the NHS, clinicians, manufacturers, patients, carers or member of the public. We really encourage notifications from anyone and welcome suggestions from all areas. The next step is the actual exploration and prioritisation. So initially, when we get a submission, we check the topic to make sure that that is covered within HTW's remit of work. So like I said earlier, we look at all types of health technologies that are non-medicines, like devices, diagnostics, psychological therapies, physiotherapy. If there is something that isn't within our remit, then it's passed to our signposting group. They act as a front door for such topics and can signpost the topic proposers or the technology developers to other organisations across Wales who can help them with that technology. If it is suitable for HTW's remit, the next step is to do the topic exploration report. And this is a very brief high-level search and report to determine the availability of evidence. So it's usually 2 to 3 pages long. It doesn't really go into detail on what the evidence is in terms of quality, but it really focuses on what evidence is there and if there is enough to inform an assessment. And also we try to identify any uncertainties about the topic that could be addressed by the topic proposer or any experts at this stage. All of our topic exploration reports are published on the website, regardless of how much evidence is there, because we find that they are quite informative for people to know what evidence is available on particular topics. The NICE equivalent is called a briefing note. They're not publicly available at this time. So on this slide, I've got a couple of examples of these topic exploration reports that we've done. 2 very different topics. On the left, we've got a topic exploration report for a digital triage platform, so a digital technology, people presenting for emergency and urgent care settings. And the right-hand side is continuous glucose monitoring in pregnancy. And this is a topic that did go onto our work programme, so we'll be bringing this in as we go through our steps. And once the report is written, it goes to one of our committees known as our assessment group, and they quality assure our methods. The membership is independent of Health Technology Wales, and you can go on our website if you want to look at the current membership. They review the TER, or topic exploration report, and decide whether or not the topic should be accepted onto the appraisal work programme. So like I said earlier, appraisal is just another term for HTA. The topics are then prioritised so that the highest priority or of most value are appraised first through our work programme. Once a topic is on the work programme, the next step is to develop the protocol or the research question. This is really important because it really refines and limits the extent of what we are looking at in the evidence review, and it can be particularly important for technologies that can be used in multiple ways or multiple settings. For example, ultrasound devices that can be used to scan for multiple conditions or can be used in lots of different settings, from primary care through to emergency care or secondary care. It's really important to know where you're directing your evidence base. This then guides the staff conducting the review and tells us which evidence should and shouldn't be included, and then therefore it impacts the final guidance outcome. What can be really useful at the start is if the topic proposer, so if you suggest a topic, you know where the value of the technology sits within the NHS. So not just what it does and how well the technology does that thing, but also what that means to the NHS and to patients is really useful. It's not essential, but it can really help. With the research question, we look at the evidence selection criteria. There's different ways that you can set out selection criteria for your evidence, but the most common, and you might have seen this before, is called a PICO. So it's a population, intervention, comparator and outcomes. So population is the condition or disease, the severity, age group, setting. You can add extra detail there if you are wanting to really clarify the type of group. So if there's a risk, high risk group that you are focusing on. There's the intervention, which is the technology or topic of interest, so or the intervention it's used for. This can be, when you're setting out this criteria, device specific or generic. Health Technology Wales tends to look at things in a more generic way because you want to get the full breadth of evidence for that particular device or intervention, but it really depends on the context, and sometimes you do need to go more specific. You also need to define what the comparator is, the current standard care. This can be really difficult though, because there can be multiple alternatives. There's variation between healthcare providers a lot of the time and patient groups. And if you're looking at what the guidelines say, that doesn't necessarily reflect what you then see in reality. So it's important to capture those things and be aware of those. And outcomes are all potentially important outcomes, the clinical and system outcomes, benefits and costs or disbenefits. So it can be negative consequences as well as the good consequences. And all of this is informed by the topic proposer, experts as needed, the evidence that we pick out during the topic exploration report, and it can also include manufacturer claims as well. All of this information is used as then the recipe to direct the HTA staff in the evidence review and tell us what we are looking for. We've included here an example PICO. So this is the continuous glucose monitoring that I mentioned before. The research question is, what is the clinical and cost effectiveness of continuous glucose monitoring in pregnant women with type 1 diabetes? So the population here is really straightforward, pregnant women with type 1 diabetes. The intervention is continuous glucose monitoring, and you can see there we've also got an exclusion with the flash glucose. Comparator is standard care, and we've got some examples there that it's usually the capillary blood glucose monitoring or self-monitoring of blood glucose. And finally, we've got some outcomes listed. So if you were to look at this particular evidence report online, you would see that the outcomes are there are a lot more than what I've included here, but these are just to give an idea. So it can, for this example, it includes some maternal outcomes and fetal outcomes, things like quality of life, patient satisfaction. What's also good to look out for is any change in patient management, if that's being captured in the evidence, and adverse events. There's also sometimes other considerations that you want to capture. For example, if you wanted to be clear that you were looking at focusing on English only data, English only publications, but also date limits can often be used. For example, if you are looking at a particular technology, say a digital app, and it's only been around for 2 years, you know that you only need to look within those from 2 years onwards, so you can limit the dates accordingly, which will help keep the evidence numbers down. So once you've defined the protocol and got the selection criteria ready, it's time to do the fuller evidence review and the consultation, which for HTW we write up this review, and it's called our Evidence Appraisal Report. And this is when I will pass over to Jenny.
Thank you, Lauren. So I'm Jenny Washington, and I'm the Information Specialist for Health Technology Wales, and I'm going to take you through how we go about conducting our evidence review to produce our Evidence Appraisal Report. So once you define the question, and you know, as in the PICO, you know what it is you're trying to cover, the first thing you have to do is decide whether or not you're doing a full systematic review or a rapid review. Now, it's already been mentioned that at HTW we undertake rapid reviews, but here's a slide explaining the differences between the two. So a full systematic review is comprehensive, It's long and can be expensive because it can take years, and by the time it's published it risks being out of date because the data that's included, the clinical trials that have been appraised within the report, were published quite a long time ago, and it may be that other papers have been published since. We call them sensitive searches. So what we're trying to do is identify every single paper that's been published on this topic in the field that you're interested in. Often a full systematic review only looks at randomised controlled trials, and if you've ever heard of a Cochrane review, these are a good example of this type of review. Rapid reviews, on the other hand, often have a narrower, what we call, focus, and in this case what we mean is we're limiting the evidence that we're going to appraise. We do this can do this by narrowing the PICO or simplifying the analysis that's undertaken, and often these only take months. Don't be fooled in thinking that just because we're doing it over a short time period, it doesn't mean that we're following a standard methodology. We are, and it's still systematic, it's still judicious, and it's still critical. And at the end of the day, just like the full systematic review, we develop an unbiased evaluation of the evidence that's been presented. The key thing about a rapid review is it's much faster and is less resource intensive. So the downside of this is it may not cover every single last piece of evidence that has been published on the topic because of the nature of the work. The first thing you have to do when you are undertaking an evidence appraisal is to identify the evidence that you want to look at. So the two aspects of this are the search and the sift. The first thing to do is the searching, which is where you're identifying all potentially relevant papers on the topic in question. To do this, we use the PICO to inform the search strategy terms, and principally in this case we use the population and the intervention. So the population is, for example, in the pregnancy example that Lauren's been talking about, this is your pregnant women with type 1 diabetes. And then the intervention is what you're evaluating. So in this case we'll be evaluating the continuous glucose monitoring. So we use these concepts, as we call them, to build the search strategy, and we use Boolean logic to make sure that we include all the synonyms and different ways that the population and the intervention can be described, to ensure that we're picking up all the papers that refer to this topic, because lots of different authors will describe them in different ways. So we want to think about all the different ways different things are talked about to ensure that we're picking up every occurrence that we can. We use a predefined list of key reference databases and websites to search. For each topic, the person who's defining the search strategy will think about which are the key sources that we need to look at. When we are undertaking these reviews, the three databases of Medline, Embase and the Cochrane Library are always searched, but there are other websites of other HTA agencies or other key sources that are also looked at to see if we can identify publications that are published on those sites. One of the other things that we have to think about when we're doing our searching is what we define as sensitivity and specificity. Basically, is how broad or how narrow the search is, and I'll go on to that in a little bit more detail shortly. Once we've identified all the papers that are potentially relevant, we have to undertake a process that we call sifting. And sifting is where you're identifying the relevant papers from those that have been found in the search. So you end up, sometimes it can be thousands of records of papers that have been published that are potentially relevant to the topic. So the researcher will look at the title and abstract of every single one of these, say, 1,000 records to determine whether they're potentially relevant. Those that they have determined that are potentially relevant by reading the title and abstract, they will then look at the full text to confirm whether or not they really are relevant. And this is where the inclusion and exclusion criteria come in that have been defined in the PICO. They're used to determine whether or not these are relevant, and also whether or not they fit the population and the intervention that have been defined in the PICO. So I mentioned broad versus narrow in terms of searching. So when you're undertaking a full systematic review, you're trying to be as sensitive as possible. You are trying to identify every single possible occurrence or paper that's been published on the topic in question. So many studies are identified, and if your search is so broad that you've picked up everything, it could be that you're wasting a bit of time because there are so many studies that have been picked up, but a lot of them are irrelevant. It may be that for every 100 papers that you've identified, only one of them is relevant to your topic, which makes it tricky to pick out those that are truly relevant. On the other hand, if your search is too narrow or specific, it may be that you've not picked up every relevant topic. And therefore, because you've not picked up every paper that is relevant to the topic, you may not have some key papers and you could come to inappropriate conclusions. However, studies have been done where they compare a full systematic review versus a rapid review to see what conclusions they have come to, and the vast majority of the time they come to broadly the same conclusions, implying that a rapid review won't miss the key papers. The diagram at the bottom of the screen there shows that when you do a systematic review, you're trying to be as sensitive as possible, and the rapid review is more specific because you're trying to only pick out the key papers and not spend too much time sifting out irrelevant studies. So once you've identified all the relevant papers, the next stage is what we term critical appraisal. And the idea behind critical appraisal is not to just about reading the paper, it's reading the clinical study to see whether the study has been carried out in such a way that you can trust the results. So one definition of critical appraisal is that it's the application of rules of evidence to a study to assess the validity of the data, the completeness of the reporting, the methods and procedures, conclusions, and compliance with ethical standards. Or alternatively, in Tricia Greenhalgh's words, she's defined it as the science of trashing papers. You're not saying you disagree with the conclusions. What you're trying to do is you're trying to work out how likely the conclusions are to be true, based on the way the study has been designed and the way the data has been presented and collected. So don't worry, I'm going to go into that in a little bit more detail now. So excuse me, there are lots of different things that you have to think about when you're undertaking critical appraisal of clinical studies. And you can see them listed here. So we've got the types of study design, the types of bias, correlation and causation, confounding, random error, comparators and outcomes, vested interests, and why many studies are better than one. Don't start panicking now, because lots of organisations have developed what we call checklists for critical appraisal, which are forms that step you through the process of evaluating or appraising the study to see whether or not it fits within the framework that it should. And towards the end of this section, we have a list of some of the critical appraisal checklists that organisations have produced. So let me explain some of these in a little bit more detail. So the first thing you have to think about is the study design and the different types of study design that are available. The first thing that we think about, certainly at a rapid review stage, are systematic reviews and meta-analyses. And what these are papers which summarise a number of different studies on the same topic to see what conclusions they can reach by looking at multiple studies. Randomised controlled trials are trials which compare one intervention against another to determine which intervention is superior. Sometimes you can have controlled trials where the trial isn't randomised, but equally the kind of gold standard for testing an intervention is a randomised controlled trial. You then have observational studies. And what's key about an observational study is that nothing is done to the group of patients or group of people that have been identified for these. You are observing what happens to them over a specified period of time. There are a number of different types of those depending on the time period that you're looking at. So we have cohort studies, and what these are they're prospective. They look forwards in times to identify what happens to the patients. So you identify your group of patients, be it your pregnant diabetic mothers or mothers to be, and you look forward over a specified period of time, whether it's a few weeks, months or years, to see what has happened to them over that time period. Case control studies are the reverse. You identify your group of people, but you look backwards, retrospectively, to see if something happened to them previously that has led to them being in this situation. Cross-sectional studies are where you get a snapshot of a moment in time. You're not looking forward or backwards, you're just seeing what's happening right at this moment when the study is happening. And lastly, for observational studies, we have case studies, which are a report of an individual patient's case. So you're not comparing it with other patients or looking at a group of patients, you're just talking about one patient or maybe two patients. And at the bottom of the slide, we have expert opinion. And the thing about expert opinion you have to bear in mind is that anybody is affected by their personal experiences, and whatever experiences they have had will influence their feelings about a particular topic. The next thing that we have to think about in terms of a critical appraisal is what we call a type of bias. So bias can be defined as a flaw in the study design, conduct or reporting which may render the results invalid. It's not saying it will, but there's a chance that it has influenced it in some way. So there are a number of different types of bias. But don't worry too much about them. Again, we have tools that help you evaluate what we call the risk of bias to determine whether you think the study is biased for whatever reason. So the different types of bias that we've got listed here today are sampling bias, which is where participants do not represent the whole patient population, which would then mean that you cannot generalise to the whole population from what the results of the study. Allocation bias is where you have differences in the baseline between the study groups, and what we mean by that is that, however it could be unintentional, the two study groups within a trial have something that makes them different. It could be that you have patients that have higher risk are all in one group, or more of them are in one group than another. For example, in going back to our pregnancy example that we've been using, that it's commonly accepted that women who have a higher BMI are in a higher risk group in pregnancy. So if you ended up with all your ladies who are technically obese in one group, then that might give you a bias in your results, not because of anything you're doing in your study, but because of just how the groups are formed. Performance bias are differences in the care received other than the intervention. It may be in your trial that if you're receiving the intervention that's being tested, you might have more visits to clinic or have more nurses come to visit you at home than you were if you're under the standard care trial, and that in itself may influence the results, not because of any difference between the intervention, but just because of how the patients are feeling cared for. You have attrition or exclusion bias, which is where more participants drop out of one group than another. And then we have detection and assessment bias, which is where the outcomes are measured differently in the study groups. So if you're recording your data differently in the different groups, then things are going to be different when you come to analyse the data. There's reporting bias as well, which is where you could perhaps only report the outcomes that are positive or interesting, but not bother reporting the negative outcomes because people might not want to know about those. Or you analyse the data in a number of different ways and then choose which one you want to report on, rather than showing everything that you've reported. And lastly, we have something called publication bias. If you have a trial that comes out with a negative result, say that the intervention wasn't better than standard care perhaps, then these are less likely to be published than those which give a positive result. So this next slide shows us what we call the hierarchy of evidence. You can see there's a triangle. Right at the very top of the triangle we have systematic reviews, meta-analyses of RCTs. Then we have randomised control trials down through the observational studies, and right at the bottom we have our expert opinion. On the left hand side you can see we have arrows determining the quality of evidence. So the higher up the pyramid you go, the higher the level of evidence, higher the quality of the evidence is, therefore the more likely you are to be able to trust the results. And down the bottom you have the lower one. And then on the right hand side, as you go up the tree, there's a lower risk of bias, because in some respects you might say that the study design is more rigorous and follows a more defined pathway than it might if you were lower down and you've got a case report, or even in some respects expert opinion. It might seem weird having the expert opinion right at the bottom and having the lowest level of quality of evidence, but as I said earlier about everyone being influenced by their personal experiences, if you were to get half a dozen experts on a particular topic in a room, the chances are that there will be dissension between some of them, that not everybody will have the same opinion about whatever the topic is. And I'm sure you find that in your daily life as well. So the other factors that you have to think about when undertaking appraisal clinical studies, and I'm only going to go through these briefly, are correlation and causation. Just because you found a link between two things does not prove that one has caused the other. It may have done, but it doesn't prove that that's the case. Confounding is where some other factor is influencing the results and not the intervention. So something else has interfered with your study that you may have not thought about, and that is giving you the difference in the results between the arms of the trial, not the actual intervention that you're testing. Random error is something which affects the results in both directions and is very difficult to mitigate or to plan for. But the thing about random error is it affects everything, and it just decreases the precision of the results as opposed to forcing it to go in one direction or another. The choice of outcome measure and comparator will affect the results of the study. Because if you're not collecting the data, you have to define these before you start. And if you don't define them before you start, you therefore may not collect the data that you want to analyse at the end. And you may find that when you come to do the analysis, you haven't collected the one key piece of information, which means you can't do the analysis you want to. And then it's not exactly easy to go back retrospectively and find and collect that data. And vested interests. Who funded the sponsored study? If a study is sponsored by industry, there's a high risk of bias as the sponsor has overall control of the study. Now, it's well accepted in health technology assessment terms that if you have a pharmaceutical study that is funded, or sponsored rather, by the company that makes the drug, then it's more likely that the trial itself will have a positive outcome in favour of the drug in question that's being tested. The last thing I want to talk about with regards to critical appraisal of studies is why many studies are better than one. Systematic review, or meta-analysis, looks at multiple studies which consider the same intervention. The more studies you have on the same intervention, the more likely the true results will be shown. This might seem a little bit tricky to get your head around, so I've got an example here which is something that hopefully most of you will be able to follow. So if you think about flipping an unbiased coin, and if you were to flip the coin 10 times, your possible results are all heads, all tails, or a combination of the two. We know that the coin is unbiased, so the chance of a head or a tail is the same. But one set of 10 flips may not show this. So the way to kind of evaluate this would be to repeat the experiment a number of times. So on the next slide, we have a little table where I genuinely sat and flipped a 50p coin 100 times to see, in groups of 10, to see how it came out. And you can see from the number of heads and the number of tails that we've got a spread varying from 1 head and 9 tails to 8 heads and 2 tails. But you can see, if you look, that 6 of the 10 sets all fell within the 4 to 6 numbers of heads. So on the next slide, it highlights those ones so you can see them really clearly. Thank you, Lauren. And so you can see that most of the flips, the sets of flips, you end up with roughly half of heads and tails, which leads you to think that yes, this probably was an unbiased coin. So what you can do is you can plot these on a graph to give you an indication of how they fall. So on the next slide is a what we call a graph showing the distribution of the probability of getting heads when flipping the coin, and you can see we have what's termed the normal distribution, or bell curve, where the vast majority of results are in the 4 to 6 range, with the peak being against the 5, so 5 heads and 5 tails from a group of 10 flips. But you're going to have 1 or 2 what we call outliers, down some where you've got 1 head out of the 10 flips and some where you've got 9 heads out of the 10 flips. And this is what you would expect when you're doing any kind of study. You would get, if you're doing an experiment multiple times, you get a variety of results. So you can put this back in terms of critical appraisal of clinical studies and systematic reviews. And excuse me, can we have the next slide, please, Lauren? And the top 2 points are what I said earlier. So the same principle holds with clinical studies. You test the intervention with a number of different clinical studies, and a true result is likely to be shown by some of the studies. So if you analyse the results from these clinical studies together, you will identify which result is the true one, because you could hopefully plot something similar to the curve we just looked at, and you can see the true result comes out because more studies have shown that result than any of the other ones. So on the next slide, we have the list of organisations that have produced critical appraisal checklists. This list is by no means exhaustive. It's just some of the ones that we at HTW are aware of that produce checklists. One thing to point out is that there are different checklists for the different types of study design, because things that make a systematic review or meta-analysis good are very different to things that make an observational study good, or a randomised controlled trial. So if you're interested, you can go onto these sites and have a look at the different checklists that they have produced. The next thing that we have to think about, or another thing that we think about when we're undertaking health technology assessment, is the health economics of the intervention. Now, I'm aware that some of you will have attended the session on Monday, and that if you want to find out more about that, I do understand that there will be a recording made available of Monday's session should you wish to catch up if you didn't attend it. But these are, I've just got a couple of slides giving you a very, very brief overview of what is health economics. It can be defined as the study of attempts to allocate limited healthcare resources among unlimited wants and needs to achieve the maximum health benefit for society. So it's a little bit like what Lauren was talking about. If you have you don't have an unlimited budget, so you've got to try and work out where best to apply the money to get the maximum health benefits for everybody in NHS Wales, everybody in Wales. So health economic evaluation provides crucial evidence on cost and cost effectiveness as part of the HTA to help us make those decisions. When we're undertaking the search, we look for economic evidence as well as the clinical evidence, so to help us to see if anybody's published a cost effectiveness study on the intervention in question, so we can use that to inform our results. Excuse me. And if necessary, we can also develop de novo or new economic models to help us come to conclusions about this, because if the topic hasn't, if the subject, there hasn't been a cost effectiveness study perhaps of the topic, then we can develop our own. But this is dependent on the quality of the available clinical evidence. The other thing that we can do is either before guidance is produced or after the guidance is produced, is conduct a budget impact analysis, which is where we're trying to evaluate what the cost of implementing a new intervention would be to the service as a whole, so to NHS Wales as a whole. And this slide is a little graph to give you an impression of what it is we're trying to identify when we're undertaking economic evaluation. So the the thing that we're trying to find is an intervention which is more effective and less costly than the standard care. So you can see on the right hand side of the graph we have things that are more effective. So clinically they are more effective than the standard care. But at the top half of the graph you can see things that are more costly, and the bottom half you can see things that are less costly. So it may be that what we're trying to find are things that are more effective and less costly, but it may be that we have something that is more effective and more costly, but it might be that if that particular intervention, whatever it may be, is used earlier on in the patient's pathway, it may mean that yes, it's more costly at this point in time, but it might lead to fewer costs further down the pathway for the patient, so fewer hospital stays perhaps, or fewer drugs to be taken long term, or whatever it may be. So it may be that sometimes something that is more costly is approved for use because it is more effective and will help the patients in the long run and actually cost less money overall in terms of the patient pathway. So once we have done all our appraisal, the clinical appraisal and the cost effectiveness and health economic appraisal, as well as looked into patient and organisational issues, we then summarise everything that we have discovered into what we call an evidence appraisal report, or an EAR. These go to our independent assessment group, who review it. Once it's been reviewed by them, the EAR is then sent out to relevant stakeholders for external consultation. So we get some input from people outside our organisation to see whether or not they think that the conclusions that have been drawn by our researchers looking at the evidence are fair. And then once excuse me, once we've had the comments back, then the EAR is then once again presented to another assessment group so that they can evaluate it based on the expert comments. And once this is done, it then goes forward for production of the guidance, which is the next stage in the process. And Lauren's going to take you through that stage.
Thanks, Jenny. So once you get to this stage, it goes on for you've got the evidence appraisal report, you've got the review. So we're just now looking at the decision making beyond that. So sometimes if the HTA is information only, then decisions are, the report or review would be shared, published, and the decisions are left to HTA users or the audience to interpret that and do their own decision making. Some organisations, HTA organisations though, have the explicit criteria for decision making process and make the decision making process, and that's usually done by a committee of stakeholders. That's what Health Technology Wales has. It's called our appraisal panel, and they make the decision and produce guidance with recommendations. Like with assessment group, the members are independent of HTW, and there is a web page on our website which shows the current membership. So something else to think about is, I mentioned earlier that patient issues are taken into account. So as part of the main review for the Evidence Appraisal Report that Health Technology Wales does, we do a lit search for the clinical and cost effectiveness evidence, but any papers that we identify from that search on patients, carers or service user perspectives are identified and written up within the Evidence Appraisal Report. But beyond that, it's also important to have patient and carer involvement in HTA because it brings forward the unique experiences and knowledge that aren't necessarily represented in clinical studies. So Health Technology Wales, we have our PPI standing group because we are committed to having the meaningful PPI as part of our appraisals and also in our wider work as well, but we're focusing on appraisals today. So we incorporate it within our appraisal processes. They determine, the PPI standing group, they look at the topics that we have on our work programme and they determine an appropriate mechanism for PPI for each topic on that work programme. And this can include, there's a few different ways, a few different mechanisms, but it can include things like a targeted literature search on patient care issues. So like I said, normally we identify papers in our standard search, but that search wasn't targeted for patient care issues. So we sometimes do a more targeted search where we can explore that in more detail. Another option is workshops that can discuss patient care issues and also participation, bringing in participation from patient organisations or groups. So that can include things like sending them the evidence appraisal report for comment, inviting them to submit their own patient reports or surveys from patients, and also we have invited patient organisations and patients to come and talk at the appraisal panel where appropriate as well to give their experiences. We've got 2 PPI public partners and they sit on both of our assessment groups and appraisal panel. We have 4 in total, 2 on each. So 2 on assessment group, 2 on appraisal panel, and they inform the work and guidance, providing their input, and they also help summarise any PPI mechanism results that we may have. And for each topic, you know, they're all so different, as you'll have seen from the start of the presentation. So the mechanism used, and you can even use a combination of different mechanisms. It all depends. It's a case-by-case basis. We look at what's most appropriate for that topic. So at appraisal panel, they will review all of the evidence and considerations and produce our decision making. So the usual decision outcomes for guidance are recommended, so that the technology has the green light to be adopted within the topic in question. The second one is recommended with conditions or caveats, so that it can also be referred to as a partial adoption. So it might be that the technology is recommended within a certain subpopulation of the group with the conditions that you were looking at, say if there was a high risk group. Another outcome is more research needed or insufficient evidence. So it's not necessarily that it's not recommended based on the evidence, it's just at the current time looking at this topic there is insufficient evidence to adopt either way. And then finally, there is a not recommended, and that is usually because there is evidence out there, but it's recommending that the technology is not clinically or cost effective. It can be a combination of the two, and that it should not be adopted. This guidance is usually written in-house by a HTA organisation, and it can be open to review depending on the HTA agency. The final thing I want to mention is that the HTW guidance has a status of adopt or justify, which means that ideally the guidance recommendations should be adopted, or there should be a justified reason why not. Here are a couple of examples of those final guidance. The guidance is a couple of pages long, but this box is the key recommendations. The guidance also includes a very brief summary of the evidence appraisal report, and also it lists the considerations the appraisal panel took when they were deliberating over this guidance. So on the left, again, you can see the continuous glucose monitoring in pregnant women. This got a recommendation because the evidence supported the case for adoption. And then on the right, we have multi-grip myoelectric upper limb prosthetics, which the outcome of that appraisal was that it showed promise, but the evidence at the time is insufficient to support the routine adoption of that technology. And like I said, they all have this little box at the bottom that the status is that NHS Wales should adopt the guidance or justify why it hasn't been followed, and we are building our function to evaluate the impact of that guidance. This slide just shows our appraisals to date. So since we launched in 2017, November 2017, we've had 21 full evidence appraisals for 21 different topics, and from that 15 pieces of guidance are currently published online. Of that, you can see that most of them, 55%, just over half, are insufficient evidence. We've got some routine adoption and selective adoptions, and the little pie on the right hand side shows you where topics have come from, where they've been suggested from. And the end game for all of this really is that we want to encourage adoption of the clinically and cost-effective technologies, those that are of the most value, discourage adoption of technologies that are unsupported by evidence, or encourage disinvestment in technologies that are no longer as effective as they could be, and improve, the final bottom line is to improve quality of care and patient outcomes. Once the guidance is written and finalised, the final step is to publish and disseminate, which is, with Health Technology Wales, our guidance and the full evidence appraisal report is published on Health Technology Wales' website and shared on our social media. It's put on the same page. We have a topic page for each topic, and you will find the topic exploration report, the evidence appraisal report, and the guidance on there. The guidance is also disseminated to key stakeholders, experts who were involved in the process during the consultation and other stages like that. And also we have a guidance alert e-newsletter that we sent out. And again, the final step is that ideally it should be adopted based on the recommendations. That is the end of the webinar and going through all these steps for health technology assessment. It's been quite a rapid whistle-stop tour. If you do want to find out more, we did have the health economics workshop earlier this week, and we are going to be looking in the future at doing more of these digital. As Dee mentioned at the start, this was our first week doing the digital versions, and we've really condensed down the content because it used to be half a day for this webinar, which is why it's been quite a whistle-stop overview of going through all of these steps. But I would keep an eye out for more of these kind of workshops, and if you are interested in more details on the economics because you missed it earlier this week, we are also looking at developing the more advanced workshops. So for this workshop, it will be the advanced workshop looking at more critical appraisal of evidence in more detail. Jenny gave a really good overview, but it's a lot to go through. So focusing more on that and going into more depth on things like the biases and the study designs would be the focus of the advanced webinar. Another way to get involved is to observe an appraisal panel. They used to be in person, but they are now virtual, and you can register to attend through our website to see the upcoming meeting, and you can view the public part. Again, suggesting a topic would always be welcomed. If you know about a technology that you think can make a difference to the health and social care in Wales, then we want to hear about it. Also, manufacturers might be interested. If you haven't heard of it already, you can register your technology on Health Tech Connect. So that's a database that NICE are in charge of, and there are different data accessors. Life Science Hub and Wales and Health Technology Wales are data accessors, and it's a place where you can just fill in the information on your technology, and different data accessors can then see that all in one place and then offer their support and work with you on that. Finally, if you want to hear more about our work and keep an eye out for things like our webinars and other events, we've got our website. There's a bit link there which will take you to registering for our quarterly e-newsletter, and also you could subscribe to our guidance alerts. We're on Twitter and LinkedIn as well. And that is it from us. Thank you very much. Diolch yn fawr. And any questions, I guess? I'll hand over to Dewi now.
Thank you, Lauren. Thank you, Jenny, as well. We've had some questions come through, which is great. I'm in a position to answer the first one myself. So Stephanie has asked, will this be recorded and shared? I missed the one on Monday. I would really like to catch up. I'm informed that there will be, so keep an eye on Life Sciences Hub communications for that. That's for both this session and our health economics session on Monday. And the same goes for the question from Anonymous. Will the slides be available after the talk? Yes, we'll make them available. So going ahead to the questions for Lauren and Jenny. Lauren, I'll start with you. So the most liked question after that is again from Anonymous, which asks, are apps within the Health Technology Wales remit?
Yes, they are. So we do look at apps as well, digital technologies. So I would say if you think that you know an app that might be of interest for us to appraise, I would suggest going to our website and filling in the suggest a topic form. Yes, but we have been looking at the Digital Health Technologies Evidence Standards Framework that NICE published, and implementing that into our processes. So we would encourage any submissions.
Thank you.
Yeah.
So the next question is from Phil, who asks, do Health Technology Wales routinely perform horizon scanning for devices? If so, what processes do you follow? Lauren, I thought this might be an opportunity to raise awareness of open topic calls that we've done in the past.
Yeah, so we don't do horizon scanning in the more formal sense. We are data accessors on Health Tech Connect, like I just mentioned, which is a way of looking for technologies early on. If you are a manufacturer and you register your technology there, that is really helpful for us to look at and do our forward planning. And yes, Dewi's mentioned our open topic calls. So we have our submission form online, but every year we have done an open topic call, which is a campaign to encourage as many suggestions as possible, especially within areas of particular need or interest.
Thank you, Lauren.
Okay.
So my next question probably is best suited to Jenny. It's from, I apologize if I pronounce this wrong, Cuckoo, I think it said, who has asked, does rapid review involve peer review on the results?
You're muted, Jenny.
Yeah, sorry, just realised I'd muted myself. Yes, if you remember when I talked about the process, we our evidence appraisal reports are sent out to peer review, not peer review, we don't call it peer review, we call it expert consultation. So fundamentally that is a peer review process to ensure that we've followed the right methodology and that we've covered the right things and coming to the right conclusion.
Thank you, Jenny. I've got another question for you here from Will. So Will has asked, publication bias, less likelihood of publishing negative results. Is that because researchers are less likely to put them forward for publication, or is it because publishers are less likely to publish them, or both? I know that's quite a definitive question, but
yes,
can you give us maybe your general thoughts on that?
Yes, I would say that the answer is both. One thing I do know though is if your first language is not English, then if there are journals that are published in your native tongue, then you've probably got more chance of getting a negative result published in a journal that's in your native tongue than in English. It's much harder to get negative results published in English, probably because a lot of the publishers are looking for positive results and they've got so many to choose from, they're going to choose the positive over the negative. Again, that's just my opinion, but generally, yeah, negative results are less likely to be published, both because people don't put them forward because they think they're not going to get published, and also because the publishers themselves are more interested in the positive results.
Thanks a lot, Jenny. That's great. Lauren, one last question, which I think you might be best placed to answer, from Alice, who has asked if there is insufficient evidence, I should say, or more research needed. Are these topics automatically looked at again after a period of time, or do they need to be submitted again for review by Health Technology Wales?
So we do plan to review our guidance. If there is substantial new evidence that gets flagged to us, we don't actively check for updates all the time, but we aim to update guidance or review whether or not a guidance should be updated every 2 to 3 years. But obviously, should there be some really important evidence that comes out in the meantime that stakeholders flag to us, then that would trigger the potential review. I call it a review, even though it's called an evidence review anyway. But it would trigger us to relook at the topic sooner, potentially. We're just going through the first of these now, because we've been around for not quite 3 years. So we are now just trialing, and we're establishing our process for that. So yes, we do look at them again. And we often, in our guidance, we make acknowledgement or considerations or things that we would like to see within the evidence as well, to help make the decision if we look at it again.
Wonderful. Thank you, Lauren, and thank you both for answering those questions. If any questions have gone unanswered, we'll answer them and circulate the answers via email. At the end of this week, the Life Sciences Hub will be circulating a feedback form. We'd really welcome your honest opinions on this session and the previous session if you attended that, and that will help us to improve these workshops for future attendees and potentially inform an advanced sequel to today's presentation. Before we depart, just a quick reminder to visit the Health Technology Wales website, which is www.healthtechnology.wales. There you can find our reports and our guidance. You can sign up to our newsletters that were mentioned today, and you can find out more information about our scientific advice service, for example, which was launched last week and will help technology developers to optimize their plans and their route to market. There are another 10 sessions left of Value in Health Week. Check out the event section of the Life Sciences Hub Wales website to register for these, just in exactly the same way that you've done it for today's session. There's even one more to go today on value in health and the COVID recovery, which may pique your interest. That concludes today's webinar. Thank you again for joining us, and we hope to hear from you in the near future.